morning, good afternoon, and good evening to all the speakers, chairs, and wonderful audiences in different parts of the world. Welcome back to another yet informative edition of Education Lecture for You. The speaker for the first session today of our webinar is our honored guest and senior faculty from Germany, Professor Maximillian Mehdorn. Professor Mehdorn was the past professor and chairman of the Department of Neurosurgery at the University of Kiel, Germany. He was also the past president of the World Federation of Neurosurgery Committee on Neurorehabilitation and Reconstruction. He is the founder of several important organizations, including the Mehdorn Family Foundation, which aims to promote neurosurgery and neurosciences for the young neurosurgeons. He is a member of several international neurosurgery communities. He is also a noted author with over 400 articles in various peer-reviewed journals. We are extremely honored to have him today as our speaker at our webinar, and he'll be talking about history of awake craniotomy. The speaker for the second session of today is our honored guest from China, Professor Xuehai. Professor Wu is a professor in the Department of Neurosurgery, Huashan Hospital, Fudan University. His major interests are focused upon traumatic brain injury, neurointensive care, and disorder of consciousness. He's the deputy head of the 5th Craniocerebral Trauma Committee of Shanghai Medical Association and committee member of Disorder of Consciousness branch of Chinese Neuroscience Society. He's one of the writers for the Chinese Expert Consensus on the Diagnosis and Treatment of Chronic Consciousness Disorder. He's also a member and secretary of Neurocritical Care Committee of Chinese Medical Association. He's a noted author with several manuscripts in various peer-reviewed journals, and he is also an associate editor of the journal Brain Informatics. We are extremely honored to have him here today with us, and he'll be talking about disorder of consciousness patient from clinical to neuromodulation. The chair for the first session today is our distinguished and honored senior faculty from Japan, Professor Takashi Maruyama. He is a professor at the Department of Neurosurgery, Faculty of Advanced Technosurgery, FATS, Institute of Advanced Bio, Medical Engineering and Science Graduate School of Medicine, Tokyo Women Medical University, Japan. He's a member of distinguished societies like the Japan Neurosurgical Society, the Japan Society for Neuro-Oncology, and he is also a member of the Japanese Congress of Neurological Surgeon Protocol Review Committee of Japan Clinical Oncology Group, JCOG. He was the executive officer of various trials for glioma conducted in JCOG. He's also a noted author with several manuscripts in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Maximillian Mehdorn. The second chair for the second session of today is our honored guest from Germany, Dr. Georgios. Dr. Mattis is a senior consultant of neurosurgery. He leads the chronic pain and spasticity sector of the Department of Stereotactic and Functional Neurosurgery in the University of Cologne. Dr. Mattis is a member of German Neuromodulation Society, DGNM, and the International Modulation Society, INS. He served as reviewer for many international journals and is editorial board member of Neuromodulation Technology at the Neural Interface and Intervention Pain Medicine and Neuromodulation. Professor Mattis is involved in many international clinical studies and has been active as instructor for many colleagues in Germany and abroad. We are extremely grateful to him for accepting our invitation to chair the session of Professor Xuehai. On behalf of the Education Committee of the ACNS, the President, Professor Yoko Kato, I would like to welcome both the speaker and chair and audiences to this online platform of ACNS webinar. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would like to hand over this online podium to our first chair, Professor Takashi Maruyama. Professor?
Okay. My name is Takashi Maruyama. Good morning, good afternoon, and good evening for all the audience. My name is Takashi Maruyama, Tokyo Women's Medical University, and also Utsunomiya Symphony Hospital. First of all, I'd like to thank Professor Yoko Kato to have this opportunity to chair this webinar. It is a great honor for me to chair this session of the ACNS education course, especially today's speaker, Professor Maximillian Mehdorn, is one of the opinion leader for not only awake surgery, but also functional neurosurgery. He published impressive papers and such as the experience of combination awake surgery with intraoperative MRI in 2010. And Keio University has 1.5 Tesla MRI. Our department also have a low field MRI in operating theater, and we do awake surgery. So that several of his papers were very impressive and educational. He also published about the history of awake craniotomy in 2019 in World Neurosurgery. It is important to know for the young neurosurgeon about the history of this methodology. And as for brief introduction, the awake craniotomy is widely expanding and it would be going to be the standard strategy for eloquent location tumor. We had a conference in 2019, such as the Moscow International Neurosurgical Forum. There are many glioma surgeons meet together and discussed about awake surgery for glioma. There is two different directions of awake craniotomy, such as simple task and minimum mapping, or multitasks and maximum evaluation, not only simple language or motor function, but also higher cognitive functions. There are several issues remaining about awake surgery, and today I'm looking forward to learn his experience. So, Dr. Mehdorn.
Thank you very much. Thank you very much for inviting me to be with you, and it's great honor and pleasure to talk a little bit about historical aspects of awake craniotomy. That's a place where I've been working, which I've been constructing with the Neuroscience Center together with neurology, neuroradiology. We've been working there, and I retired in 2015 after having come to Kiel in 91, so 2 years before the Asian Congress of Neurological Surgeons was created. So it's always good to remember of some historical aspects of any kind of technology. Time is going by so fast, everyone invents everything. So I think it's good we have a line of tradition, and certainly Dr. Masses likes this because Köln is somewhere very, very important place. And there are many other places here like Köln, Nittner, Sturm, and many others. And so there are many generations of stereotactic neurosurgery. And I thought it might be interesting to look through the same as well. And we, Kiel here is here, Deutsche, Mehdorn, and we spread our news and knowledge as well somewhere other places. So awake craniotomy is defined when the patient is more or less awake to follow commands during surgery, when the perforation of the skull is performed, but more than just a burr hole. So it's strictly speaking, awake craniotomy is not when you do, for example, when you do burr holes for deep brain stimulation, that's not, it's also kind of awake craniotomy, but not just this. This is a very ancient technique for religious purposes, has been used since centuries or millenniums, and nowadays in Africa is still used for healers. Very late in this, only surgeons came into the screen. When you look at PubMed articles on awake craniotomies, you see all these articles before World War II, regional anesthesia was often the anesthetic method of choice for intracranial operations because no good anesthetic therapy was available. But when you look at the articles on awake craniotomies published in the last 40 or 50 years, you see 75, 77, all the way up to 95. There were very few articles only, be it for awake craniotomy or even less for awake craniotomy for brain tumors. And only in the late 90s, early 2000s, there came up a real rise of these articles of the publications. Here was mostly anesthetic publication, anesthesiological publications, or also experimental studies performed on for perfusion and all the others. So let's look a little bit more into these details. Why do we perform awake craniotomy? There's a long history trying to understand the functional anatomy of the brain, which goes back to the second part of the 19th century. There are names like Broca with his aphasia, expressive aphasia, and frontal lesions, Hugh Jackson, cortical discharges led to focal seizures, Fritsch and Hetzig, they studied in the laboratory. It's very important always to have the patient as kind of laboratory, but also to have good laboratory expertise on all this evolution of modern technology, modern knowledge of the brain or other structures. So they studied on excitability of the dog brain, and truly this Englishman, Robert Bartlett, was the first one to electrically stimulate the human brain already in 1874, but he caused generalized seizures in the lady with ulcerous epithelioma. So that's this man, he didn't talk to the lady before, obviously, and she was very frightened because her brain was lying on the surface. So the nice summary is written by Topische Diagnostik von Gehirnkrankheiten, the clinical study by this very famous Professor Dr. Hermann Nothnagel. I just mentioned him because you'll see it in a few slides later. Clinical study published in 1879 in Berlin, and as many of these studies have been published in Berlin and in Vienna as well. And he summarizes all the different symptoms like disturbances of speech in his publication, and then the paresis of a single extremity without any other symptoms which may occur due to bleeding or embolic. So there were always clinical pathological correlations. And so they found that they collected these data very carefully, and single patients, everyone published a patient. As you see, the case of Renault, the case of Bourdon, French people, and they got a good number of publications together. And you see, when you look at the references he cites, you have Charcot, you have Dieselhoyd, you have Romberg, you know, all these people from the literature, and it goes all the way further. You also have Wernicke here somewhere in this third publication, and you have Förster also correlate Wernicke aphasia symptoms published in 1874 in Breslau. So you have many of these. And why do I talk to you about this? Because when Harvey Cushing, who's always considered the founder of modern neurosurgery, gave his Cameron Prize lectures in university in Edinburgh in 1925. He started his lecture 3 on intracranial tumors and the surgeon with a citation from Ernst von Bergmann, who was a German surgeon, obviously living in Berlin, published in 1889, and he correlates surgery of brain abscesses to surgery of brain tumors. He says for the first one, for the abscesses, diagnostic is too little, but surgical technique is sufficient. And for the latter, the brain tumors, it's totally different. Diagnostic is already so well done that, for example, Nothnagel, whom I showed you, says, well, it's relatively simple to diagnose a brain tumor. However, the technique to treat these by circumcision, hemostasis, and prevention of brain edema is very difficult. And then he continues with all his discussions about brain tumors. I was permitted to assist Professor Sherrington when he was remapping the motor cortex of the higher anthropoids. So not only in humans, but also in animal experiments. I became familiar with this method of unipolar cortical stimulation. So it was the turn of the century approximately. And this continues when you look at Horsley, Victor Horsley. He performed the first epilepsy surgery in a patient with a depressed skull fracture. Fedor Krause, this gentleman who was working in Hamburg-Altona at this time, was still Germany. He was working there together with neurologist Oppenheim. He had operated on more than 400 epileptic patients, and he performed electrostimulation of the human motor cortex, coming very close to the homunculus as we know nowadays. Ottfried Förster, who was studied medicine also in Kiel and Breslau with Wernicke, and later was sent to Paris to work with Babinski, Desgerie, and Pierre-Marie. He performed many localization studies in patients, but also in animals. And then they wrote together the Atlas of localization of the brain on the brain. And later he became chair of the first department of neurology in Germany, single department of neurology away from internal medicine at Breslau University. He trained himself to become, that's his the gentleman on the right side, obviously. He trained himself as a neurologist to become an excellent surgeon, different from the techniques which Harvey Cushing, for example, did. But Cushing also considered him to be an excellent a surgeon in some way. He always did the best operation. All this Cushing didn't really understand the way he did it. Berger in Jena at this time, very close to, or a couple of 100 kilometers only away from Wernicke, from Breslau, he developed the EEG machine. So they were working together. So Cushing and Förster. In 1909, Cushing had published this book here, this drawing on the sketch on the motor cortex. And he also got very much interested in the work done by Förster at this time. And they worked together, like Förster was visiting frequently Cushing. Cushing was visiting and organizing a congress together with Förster in Berlin before the Nazi regime came. And because Förster was such an excellent neurologist, neurosurgeon, he had many visitors from abroad too, and one of them, one of the most important ones certainly was Walter Pellfield, who stayed 6 months with Ottfried Förster in Breslau, working in 1928, learning to operate on awake patients, not on sleep patients, so that the responses to cortical stimulation could be monitored, and they published together. Other ones were Percival Bailey, John Fulton, Paul Busey, whom I had a chance to meet later. So it was a galvanic stimulation guided resection of scars, and this published in Brain. As you can see here, that's a scar which caused the seizures, and by this galvanic stimulation around the scar, they were able to remove as much of the scar as possible so that no further seizures would occur, or as little seizures would occur, without damaging the brain. And upon return to Montreal, Penfield founded at McGill University, founded the Montreal Neurological Institute, where he continued to refine the studies which he had learned with Förster. And he provoked by electrical stimulation, spontaneous movement, speech disturbances, visual impressions. So he did not only operate on the motor area, but he also on other areas, speech, visual, occipital lobe, and the others in patients with operated for epilepsy or for tumors. And he had a group of colleagues, obviously. He had a group of residents, and one of the residents was Ed Baldry, one of the most important students. He helped in data collection, and they had all these drawings. And he, with Miss Cantley, who had been taught about drawing, medical drawings by a gentleman from Leipzig. So in 1937, the Homunculus was published in first setting, as you can see here, not just as elaborate as we now know it nowadays, but they are very, very, very similar on the motor, Rolandic, and the Rolandic sensory, as I called it in this time. So you see all what we need to know nowadays. So Baldry published this architectonic subdivision of the mammalian cerebral cortex based on 105 human cerebral cortices as his thesis in 1936. And then together with his master, Dr. Penfield, they published in Brain 37 and again in 39. So these are two pictures of Walter Penfield late in his career, 1936, and Ed Baldry, who moved to San Francisco, where I had a chance to meet him. He was a founder of the San Francisco Neurological Society and Western Neurosurgical Society. But unfortunately, and I had the chance to meet him and the San Francisco Neurological Society. I was a medical student in Zurich, 71, where I got my first impression together with Professor Kreinbühl in neurosurgery. I was a microsurgical fellow in San Francisco UCSF. And I gave a talk at the San Francisco Neurological Society also in 1971. Upon invitation, got a nice certificate, everything. And well, Dr. Baldry, he had a broad clinical and scientific interest. More than 90 publications are listed in PubMed, well read in many languages. And that's the advantage of these old people like Förster and many others, as you have seen also by Notenhagel's publication list and the references. They were well accustomed to speak their own language. In addition, they knew French, and they may have known also English. And as you can see here on amputation neuroma, simple citations from French and English and German as well. But unfortunately, he had no further contributions to Dr. Penfield's area. When I met him, he was still highly esteemed in the grand round. He was very modest, very kind. Now, coming back to awake craniotomy, the brain is not sensitive to pain, which is an advantage when you perform surgery. The patient's response to manipulation retraction is minimized by anesthetics. So it's an advantage that you can work on the brain without care, and you see immediately the responses when you do badly with a patient, or with the brain. On the other hand, when you have an uncooperative patient, doesn't work so well. If you have a cooperative patient, he becomes uncomfortable in longer operations, and we had the experience that after 3-4 hours, the patients would really get tired and cooperation would fall down. So these Mitchenfelder, the neuroanesthesiologist, wrote only for short operations that's helpful, stereotactic operations, percutaneous corticotomy, and so on. Now, coming back to the tumors. CT imaging of tumors in 82 was very poor at this time. For these times, it was considered excellent already, but if we compare to nowadays, so the discussion on awake craniotomy, there was no interest to perform these operations in the 70s, 80s for brain tumors. Penfield had started with tumors, but only for tumors who had been symptomatic with epilepsy mostly. He had one co-worker, Dr. Ward, and Dr. Ward was the mentor of Dr. Ojiman, who went to Seattle and performed epilepsy surgery with awake mapping, and he found many details about brain connectome, everything about brain localization, and so on and so on. But for tumor surgery, there was still the question of benefit of radical resection in the 70s and 80s, which is understandable on the basis of the CT scans, which you see. And Sanai and Berger, they published, summarized PubMed. You see in the early 90s, even there was equipoise between papers favoring more extensive resection, that's the blue line, or papers not really favoring, not seeing any benefit. And only afterwards in the late, there was a increase in papers favoring more extensive resections. So imaging modality, CT improved, MRI, DTI, Fmri, all this came up. And Dr. Ojiman and Dr. Berger, who had joined him in Seattle, they performed operations also for tumors, and they found that 1 centimeter safety distance is required when you go into for a tumor on the surface or also deep in the brain. Dr. Berger published on awake craniotomy and neuronavigation. We had implemented this also in the early 90s. And large versus tailored craniotomy, it has been a discussion. We favored small craniotomies, they favored, but it doesn't matter. So because of honoring Dr. Berger's contributions to the heritage of Krause and Förster, he got the medal of the German Society of Neurosurgery back a couple of years ago. So when I came to Kiel in 91, we started awake craniotomy in 94 because working together with a good psychologist and a dedicated group of neuropsychologists as part of my clinic. And we developed this and improved on this technique, and obviously became important for the general public. And you see here a newspaper article 1 year after we had started. The main point is neuronavigation, obviously, but the patient guides the surgeon. So it's a cooperation between the patient and the surgeon, and that's all about positioning the patient in sharp Mayfield pins. At this time, we were badly attacked by other neurosurgeons who wanted to do awake craniotomy, but were reluctant to put these patients. We used neuronavigation to put these patients in sharp Mayfield pin. But if we talk to the patient carefully, if we have the patient well prepared for surgery, if you have him well supervised during surgery, there's no problem. Cortical stimulation of speech area and also obviously the motor strip with phase reversal. We published gliomas in central area experience in 98 to small group, only 55 patients. Gliomas in central areas, we had a higher complete resection rate as seen in the postoperative MRI scan. We had no early termination of the operation, no intraoperative seizures, no mortality, and worsening in 12% compared to worsening in a third of them. So when we got the intraoperative MRI scan, 1.5 Tesla machine, Dr. Maruyama has mentioned already, we also introduced this with a patient, and there are a couple of patients who may become anxious, but if we talk to them very carefully, we bring them in the awake state, brought them in the awake state into the machine even twice, and that's a patient with a recurrent glioma who accepted, again, second surgery, second study during surgery also, because we had helped them very carefully. And we published these experiences a couple of years ago. Now we continue to perform the surgery even when after following tractography and refinement of fMRI studies and all this. And you see this patient, a lady who had undergone stereotactic biopsy after having had seizures elsewhere, and she came to us to get complete removal after it was shown as to be low-grade glioma. So again, we performed a awake craniotomy on her, and she did well, no positive neurological deficit. 2012. And long-time follow-ups, that's very important. We not only have to treat the patient immediately, but also supervise them how they do continuously. And that's 2008. And the complete resection follow-up in 2014. I had the chance to see her again in 2021. Last year, she was fully working with a normal MRI scan. So that's the patient we would like to have. When we compare our survival curves for primary gliomas, even for grade 3 and 4, we performed awake craniotomy with them, and to show that we don't do too much damage to them while improving the outcome, temporary outcome, even in high-grade gliomas. When using the intraoperative MRI, we also performed the awake craniotomy. I know Chinese series from Beijing Capital Hospital, they have larger series now, but we had at this time, we had the largest series, the combination of both. Now, the summary indications for awake craniotomy and the techniques: tumors, lesions in eloquent language motor areas and the surface and the fibers. For low-grade gliomas, questionable at this time. For high-grade gliomas, preoperative evaluation of fMRI, DTI, and neuropsychology preoperatively and during surgery is important. Scalp blocks, lidocaine, marcaine, mild sedation with sleep versus awake throughout. Some kind of sedation when you start the craniotomy and when you prepare the patient, but he needs to be awake immediately. So you need to have a good cooperation with the anesthesiologist. Large craniotomy to have a positive mapping of eloquent areas versus small craniotomy with negative mapping during tumor resection. This needs can be discussed. Bipolar stimulation, different from Cushing's. Monopolar stimulation has advanced, becomes more important. So the results, the San Francisco series published 14 years ago, language area gross total resection up to 2/3 of the patient new or increased language deficit at 1 week, 22%, decreasing down to less than 2% after 6 months. Open questions: the patient selection various technologies, awake craniotomy versus navigated transcranial magnetic stimulation. They preferred TMS. We performed awake craniotomy. They performed a study which they published last year. They showed a better outcome after awake craniotomy compared to this TMS. Anesthesiology is very important. Airway management is primordial. Taking all this into account and all the previous communications, a French colleague from London, I think, he said awake craniotomy may be even an option for glioblastomas. Non-intrinsic lesions like carcinoma is really necessary. Does the early stage has been suggested 6 years. We had started with 14 years of patient. And to answer some of these open questions, 2 studies have been suggested. Protocols 2 years ago, so SAFE trial, SAFE surgery for glioblastoma, awake craniotomy versus craniotomy under general anesthesia. I think the study will not really get forward because the same group started with a program study, awake mapping versus the sleep mapping for high-grade glioma. There's a 3-armed study, international multi-center, again started by the Dutch group, but together with Mitch Berger and also German Sandra Krieg. So a couple of groups are working together, and we'll see a couple of years, 6 years from now, approximately, which is the best result for these patients. To have the pedigree worldwide, we had German experience, Germany from Breslau, traveled over to München. We learned from München. I learned from Bristol as well. I learned also from Montreal. I had other colleagues going to Montpellier to see Professor Dufour operating. I do not know the Asian experience where it came from, whether they had been they did their own development or whether they had been somewhere else, be it Europe or North America. Montreal, Seattle, San Francisco, Mitch Berger, Yi Chang, Toronto, Bernstein. He is one of the surgeons who has applied it the most frequently. also being in a community hospital, working in a community hospital as well, looking at the cost efficiency. And from there, it has also been transferred to low and middle income countries. Now we've always been discussing awake craniotomy versus biopsy, supratotal, remove as much of the tumor as possible, maybe a little bit more, still guarding some safety margin versus molecular biology. So the question is still discussed, and we have to see this. So Hugues Dufault, he suggested that we should not so much look at the brain areas at the surface, but consider the connectomic brain as a total. When you see this glioma here, low-grade glioma left in the insular area, it can be safely resected when you look at all the little areas, when the fibers, and you can look very carefully at all the long fiber tracts, which have been discussed already many years ago. So he even goes to publish the death of localizationism, the concepts of functional connectome and neuroplasticity, because once you have removed a so-called eloquent area by awake mapping and removing this, and then you may be sure, or there are some indications that the function comes back. So because of the neuroplasticity. Very important, the best care of brain damaged patients. And if we go back to the roots again, there was Carl Friedrich Burdach, whom Hugues Dufault also cites, with a publication back in 1822, 1826. So 200 years ago, he was a philosopher, internist and surgeon and everything. But he was also, what is interesting to see nowadays, he was also ordinary member of the Imperial Academy of the Researchers in Moscow, and he was in Danzig, and he was in Vienna and many other areas. So he was widely traveled, and he was writing a big book, 600 and something pages, about the construction and life of brain. There are many stories in there, many discussions which are difficult to ascertain today, but they were looking finally on empiric material to realize the importance of different separate brain structures in the pathological anatomy according to certain principles. They observed disease problems, compare them with the localization of the brain anatomy, be it hematomas, be it ischemic events, be it empyema, be it atrophy, and so on and so on. And similar to what we do nowadays, we have better techniques, obviously. And he found, and that's one of the citations which Hugues Dufault refers to, already 200 years ago, that we have this radiation, the markige Strahlung, and he says that's the most important area, that because to have some function of the cortical area, which always leads to the excitation of the brain. Finally, the real fact is done by the radiation, by this deep in the white matter lying radiation. So what is important? You can discuss what is history, but what is important for the future, for presence, to keep the oncofunctional balance in surgery for different diffuse low-grade gliomas, for low-grade gliomas, also for high-grade gliomas, integrating the extent of resection into the quality of life of the patient. So we have to learn more about the brain function, and this concept has also been taken over by colleagues in Asia, as here published recently from one group in Singapore. Again, oncofunctional balance in these gliomas. Coming back to Cushing, he writes in this publication which I cited, whosoever is most ingenious in using these techniques is apt to be not only the most resourceful and skillful operator, but the one who secures the best results with the least damage to his patients. So that's what we are still looking forward. And so we have to look also, can we expand the indications? Should we expand the indications for awake craniotomy, aneurysm, AVMs? Yeah, a couple of publications on this subject. Many are kind of commercials. I'm not quite sure whether it's really beneficial for these patients. Still needs to be proven. Cavanovas, this may be helpful. Posterior fossa vestibular schwannomas, I do not really see an advantage, but maybe some people can convince me. CV junction has been suggested to use AC for positioning for great meningioma in the foramen magnum. I think evoke potential is very helpful in this. Spine surgery is coming up also in the United States for commercial business problems. Coming back to the Xuehai craniotomy, how many patients do we need to really gain a good experience? Not a single surgeon, but a group of surgeons. What are the team requirements? I've seen many small departments in Germany starting also to do a Xuehai craniotomy. I think these delicate techniques should be reserved to large volume centers. I would like to hear your opinion on this. And I think we have to always take care that the patient should be the center of our attention. And we should always have a chance to be greeted, to greet him with a good souvenir and with a good consciousness. So thank you very much for your attention. Thank you.
Thank you very much. That's a wonderful talk and so educational, and it is very important to know the history and the way we came to do awake surgery. So I'd like to ask to the panelists and also the audience about comment or questions.
May I ask a question, Professor?
Sure.
Sure.
Yeah, Professor Mehdorn, thanks for a very nice presentation on the history of awake. Do you find that is there any discrepancy? Hello, Professor.
Yeah,
hello,
I can
Professor.
hear you. No, there was a break in it.
Yeah. I just wanted to find out, based on your experience, is there any discrepancy between the iliacone area marked by Fmri or DTI compared to cortical mapping? And second question, Professor, is there any necessity to infiltrate dura with lignocaine or marcaine? My last question, Professor, is there any median time of brain plasticity? Thank you, Professor.
Concerning the time for brain plasticity is very difficult to judge depending on the damage you do to the brain. So I think it depends how severe the brain is injured. This will certainly have implications on the duration of recovery of the function. Certainly also the age of the patient is very important and the severity of the function. So it's difficult to say, but you have to wait 1 year. That's possible. So, as you have seen from the publication Xuehai Berger, which I showed about the aphasia, it took 6 weeks and then very much had recovered. But they are, if you look very more delicate in this damage business, can last longer, the recovery time. So that's one question. Then for the dura, we always have also used some not injection, but putting the paddy with anesthetic agents onto the dura, because the dura obviously and the vessels in the dura, they are pain guiding, so the patient will not love it. And if you have a tumor like a meningioma, if you would do a meningioma, would you like to peel it away from the dura? This is would be very painful to the patient. So if you have a recurrent glioma, which you would like to go in, you have to do more anesthesia on the scalp block at first time, but then also on the dura, on the scar, to not to hamper the patient to work with you when you go into the tumor, which is the most important part, because the patient only has a certain, let's say, volume of resilience against all the damage which he has to suffer again, because he anticipates when he has recurrence. But so he has a certain resilience, and when you use this resilience already, when you perform the scalp block, when you perform the skin incision, the craniotomy, he does not have enough resilience when you go for the tumor itself. So it's very important to balance. That's why you have this asleep, awake, asleep part of the business. And the first one, that is a good question. The first one concerning the differentiation between cortical mapping and Fmri studies. There is, we have been trying to do both, but we have not really been able to correlate this or refute this. So on a scientific point of basis, but because the brain is moving and stretching a little bit, so I would not really relate on the fMRI data to go into, but rather on the on-time evaluation of the function. That's why we, even when we were doing all this fMRI, DTI, and all these studies, I would always was in favor to tell the patients continue to do awake craniotomy. And I think we were right.
Yeah, thank you, Professor.
Is there a question, other question or comment? Let me have one question. Dr. Dufault proposed about supratotal removal, and some groups doing such a supratotal removal for especially for right frontal lobe. And the thing is, if we could do a supratotal removal, we have to evaluate the cognitive function during the awake. And some groups doing cognitive function, and some say that we don't have to do such a cognitive function because we cannot figure out higher cognitive function during the awake surgery. So what is your opinion, and what do you think about the supratotal removal, Dr. Mehdorn?
Do you mean super total?
Supratotal, yes.
Supratotal. Well,
supratotal.
Well, you know, I have seen many slides of Professor. I know him very well since many years, obviously, and he's an excellent surgeon. Certainly, I've also sent my people down there to see his techniques and all this, and they were fascinated by his technology. They were fascinated by his neuropsychology and everything. But still, when you look at his pictures, I didn't show these pictures when you just only have the fibers running somewhere in the vacuum or in the brain. I wonder, the brain is more delicate than only the fibers. You have to keep the balance. You have to have the balance, and you cannot study everything in the situation when the patient is in this stress state of awake craniotomy. You cannot study all the difficult different aspects of personality, which may change and so on, because also this may change not immediately. There is not a breakdown immediately, but will continue after some time. And so he always says everything comes back rapidly. But even French colleagues are very doubtful about that everything comes back so rapidly. So you have to see the patients and themselves, and he published extensively, also recently published big publications, and certainly beautiful publications with everything in detail. But sometimes you also, he may be one on the top on the Mont Blanc or on the Fujiyama, but we are all in the plane.
I see. Okay, so this is for younger neurosurgeons. So I want to mention about the indications, like a learning curve for awake surgery. Maybe the speech, language awake, and motor awake will be the essential. However, if you get familiar with awake craniotomy and you have a good team, then you can step forward to the other indications, such as let's say medial temporal, the memory, or psychological disorder. You have experience about Parkinson and also DBS. So, so what is your opinion about the next stage of awake craniotomy?
Well, I think we started awake craniotomy, as I told, in '94. We did the first patient. We discussed extensively when we started to do this awake craniotomy. We had been abroad to other places to learn from them. They made mistakes, like nothing was organized when I was visiting a certain place. The MRI scans were gone. So you have to really do it very carefully, well prepared. And we even took the time to bring the patient the day before surgery or 2 days before. We brought him into the OR, show him around so that he got accustomed. We showed him the Mayfield clamp and say, well, we take care of you, but that's a business, and we'll get some noise. You hear the craniotome and all these things. And so we started with motor. motor deficits, because I think that's the best to test. And then you also have to have a very good surgical technique, because you cannot you should be very quiet, very concentrated on the patient, but still on the other side you should also talk to the patient in between as a surgeon, say, well, everything goes well, or everything, we have to wait a little second because it's a little bit bleeding, or everything like this. So you have to have a good cooperation with the patient, notwithstanding the neuropsychologist sitting around. And I had many nice discussions with the patients in between surgery, learning what they were doing, what they had been doing about the family life and all these things. And you can use this information when you test the speech or memory functions in these patients, depending on the localization where you are. So you can do it in a formal way, or you can do it in a kind of casual way. And you see, when he is not able to tell the name of his wife, hopefully he should be able to do so, and all these things, and talk to him extensively. And doing so many open awake craniotomies made it very, very simple for us when we started deep brain stimulation, because we had all the setting going into deep brain stimulation. That's where we got very rapidly a large series in Germany from our place.
Oh, is there
There's a question. I see a question here. How you prevent convulsions? That's a very important question. You can discuss whether you should put the patient on anticonvulsants if he had seizures before already. But when you have no seizures before, you shouldn't. I think you should not put the patient on anticonvulsants just in a prophylactic way. But if he has seizures, if he may develop seizures, usually you see it when the brain starts swelling. You put an ice cool pack on the brain surface, and then the shrinks down, the seizure stops. But there again, we had very early in the second or third patient, we had a severe seizure because the anesthesiologist did not watch carefully enough, and so he got hypoxic in between. I'd say, well, there is something happening, and the anesthesiologist said, well, everything is fine, but nothing was fine. So I had to resect the mushroom coming out of the brain, and to get a good closure afterwards. But afterwards we learned that we could really learn from others as well, that we could do this with putting the ice cube on the brain surface, and everything shrinks down and the seizure stops. So you get barbiturates or diazepam, very rapid anticonvulsant medication. That's very important. And always watch the air control, airways, that they have good control.
Thank you very much. Is there any questions or comment? Thank you very much. That was absolutely fascinating lectures and so educational. And we learned a lot about history, and this is very important. You introduce us many good papers, important papers. Then we should learn more, and we have to contribute to the patient. So I'm going to wrap up the session, and let me hand it over to Dr.
Thank you, Professor Maruyama and Professor Mehdorn. We have an update regarding the audiences from all the 3 platforms we have in WeChat for audiences in China, YouTube, and also through Zoom. At the moment, we have 1,190 audiences who watch from all different platforms. And thank you, Professor. And we move on to the second part of the webinar. May I call upon Dr. Matis to introduce our second speaker and to ask him to start his lecture. Thank you, Professor.
Good morning, good afternoon, and good evening from Cologne, Germany. Thank you very much for asking me to chair this session. My name is Matis, I'm a neurosurgeon. One small clarification, I'm not a professor, only a senior consultant in the Department of Stereotactic and Functional Neurosurgery in the University of Cologne. I would like not to forget to thank Professor Mehdorn for the first slide of his presentation. He is right. Cologne has a huge tradition in stereotactic and functional neurosurgery, and I'm very proud to be part of this department. And now moving on to Professor Wu, our distinguished speaker of today, who is a professor at the neurosurgical department in Huashan Hospital, Fudan University in China. He is a committee member of the Disorders of Consciousness branch of Chinese Neuroscience Society. He is also one of the writers of the Chinese expert consensus on the diagnosis and treatment of chronic consciousness disorder. He wrote many publications, some of them in very prestigious journals with impact factors of more than 24. So the topic is even more interesting for me coming from the neuromodulation field. It's about the treatment of disorders of consciousness using neuromodulation. So I'm very happy to introduce Professor Wu. I'm looking forward to hear his presentation on how we can use the EEG analysis, the functional MRI, the deep brain stimulation, and the transcranial magnetic stimulation to help patients with such clinical problems, how we can improve their quality of life. Professor Wu, thanks for accepting the invitation for this webinar. You can take it away. The floor is all yours.
Thank you, Professor Matthias introduction. Thank you very much. Now share my PPT. Good afternoon, good night for everyone. My topic is treatment for disorders of consciousness patient from clinical to neuromodulation. As we know, the consciousness is related with the cortex, such as the frontal lobe or parietal lobe, and the thalamus and the brainstem are also key region for consciousness. But what's the consciousness mechanism? Clinically, there are several million severe TBI and stroke happened every year. With the development of a modern medicine technique, more serious cases survive in disorders of consciousness state. Mainly is in coma and a minimal conscious state and unresponsive wakefulness syndrome. In China, so many population, the biggest population every year have 70 to 150,000 cases every year. These older patients bring a huge burden to the family and society. But how we can save the patient and improve their consciousness level? Clinically, as the acute brain injury, this is the most important stage. The patient in coma. The chronic usually in disorder of consciousness, the patients usually have hydrocephalus, and neuromodulation is the promising technique. Yeah, it's the acute brain injury, when the patient in coma. As we know, the control ICP normal and keep a normal CBP and keep the brain good microcirculation and good cerebral oxygen and control the infection and precise fluid measurement. These are all key points to protect the brain function. So I show it with this case. This first case is the 7-year-old man, the boy who suffered a motor traffic accident. The first operation made in local hospital. 36 hours later, transferred to our emergency room. The patient GCS is 5. Large pupil enlarged, no sensitive to light. Obviously, is a brain hernia. This is the nose. The nose is the brain tissue come out. So the patient will be dying the infection or the high ICP. So we decided to reoperate for him. When we opened the incision, we first enlarged the bow window and remove the broken tissue and put the ICP tube into the left ventricle, and the CS fluid come out and the ICP decreased, well controlled. Then we repaired the cranial base with the fissure later. And so this is the scan of the operation. The ICP is well controlled. 7 days later, the patient can make a tongue extension as a request. This is the CT scan. 10 days later, 20 days later, the patient can speaking. But the patient have subdural hydroma. Yeah. So this is related with the craniotomy. So we decided to make a cranioplasty in advance within 2 months. 3 days after cranioplasty, the subdural hydroma disappeared. The patient recovered very well. Now it's in normal life. This case is a 7-year-old older man who suffered the aneurysm rupture, and we symbolized the aneurysm, and EVD were done, and the patient survived in vegetable state. And hydrocephalus, the VB shunts made, but the ICU pressure is very low. It's negative. It's negative, the hydrocephalus. So we try best to improve the ICP and keep the VP shunts valve the lowest. It was 0.5, and the patient conscious level needs to increase to minimal conscious state. 4 years later, the patient come to our hospital again. I tell her daughter to press the VP valve reservoir, yes, 600 times every day. The diameter of the frontal angle, lateral ventricle angle, decreased from the 67 to 62 millimeter. Patient consciousness increased distinctly. Now the patient can able to communicate. This case tells us also 4 years long, the patient in disorder consciousness, we also can improve their consciousness level by precise hydrocephalus treatment. This case is a 6-year-old female who also suffered the aneurysm rupture and in vegetable state after 6 months. We can see the lateral ventricle little large, not very large. Do we need to do VB shunt for the hydrocephalus? So this is arguments in our department. Some neurosurgeons suggest the VB shunt, but some said no, there's no need. So it's very difficult to decide what we should do. As last, I select operation, do the VB shunt and do cranioplasty, and put the lateral fissure above the titanium. Now the wood is good, but after operation, we put the VB shunt of valve pressure as the 0.5. It's the lowest. The patient is still is a vegetable state. But we can see the ventricle lateral, the ventricle is still large. Well, what we can do? So I made an EVD by the VP reservoir for more than 400 milliliters a day. For 9 days, the patient can open upon the calling. But there are so many artificial materials in the brain, such as titanium, VB shunts, aneurysm clipping, and artificial meningioma. So I dare not can continue keep the EVD. When the patient infection happened, the patient will be died. So I decided to punch, tell her doctor to punch the valve 2,000 times a day. Yeah, and 11 days later, the patient can follow orders occasionally, but the ventricle is still a little large. So I increased the punch times. As last, the patient punched the valve 4,000 a day. Now the patient can recover very well. Now the patient can care for herself, can dancing. So this case tells us the precise for the low pressure hydrocephalus. We reduce the CNS fluid and let the lateral ventricle, as normal as possible, the patient consciousness maybe can improve. So we summarize the hydrocephalus in DOC patients, 64 patients, and this is the basic information for these patients. We find that this patient, the VP Shunt valve is about 64% below the 1.0. This means, yeah, this patient is in low pressure hydrocephalus. Yeah, all these patients after operation, the GCS and the CIS increased distinctly, obviously. About 64, more than 64% have a remarkable effect. Yeah, totally more than 90% can improve consciousness. So I make a classification for hydrocephalus based on the lateral ventricle. As we know, hydrocephalus usually happen at acute stage. This patient need emergency EVD. And for the normal pressure hydrocephalus, this patient usually happen in the elderly patients. For the low pressure hydrocephalus and negative hydrocephalus usually happen in the chronic infection, CNS infection patients and potentially false craniotomy patients. Though they have different pathophysiological condition and need different treatment strategy. Now, but how to diagnose these patients for LPH and negative pressure hydrocephalus? They have very special CT imaging as follows. The subarachnoid space significantly reduced, usually missing in the convexity of the hemisphere, including the sylvian system. Most of the force ventrically enlarged can appear as a sphere with attention. We can call the bull sign. The whole brain show the stiffness on the CT imaging, indicating decreased brain compliance. Obviously, the ventricular pressure measurements all dropping below the 70. So how the mechanism we hypothesize different from the communication and obstructive hydrocephalus, low pressure and negative pressure hydrocephalus. Usually, the obstructive region is point as the median volume of the fourth ventricle. So for this, for DOC patients with hydrocephalus, we should know their detailed history and symptom change and assess their radiology imaging, including the CSF fluid, especially the midbrain aqueduct. And we also can do function MRI, including resonance data, DDI or perfusion after lumbar CS drainage. We can assess their behavior examination, such as the GCS and the CIS variation and the MMCS SE. When we decide to do operation, our principle is the good function need the normal size and the normal structure. So we want to let the ventricle to recover as normal as possible. After clinical evaluation and the CT scan and the MRI evaluation, for some patients, is not suitable for lumbar LP because for the low pressure and the negative high pressure is not suitable for LP. The VP shunts is the first choice. But so for the VP shunts, they have anti-cell phone tube and non-anti-cell phone tube. For the low pressure hydrocephalus with disorder of consciousness, and non-anti-cell phone VP tube is preferred. But how to assess the pressure doesn't need CT scan and behavior assessments. Besides hydrocephalus, the craniotomy is also very important for the consciousness. This case is a patient suffered the TBI, happened in USA, Boston. Yeah, 6 months later, come back to our hospital. The patient in vegetable state, and this is overdrained with the VB shunt. So we sutured and ligate the tube, because when increased the VB shunt to highest, they still overdrained. So after that, the patient consciousness increased to a minimal state, and 1 year later. 1 year later, we do VB shunt with the anti-sulfone VB shunts and make a cranioplasty. Now the patient can thinking as normal. He can stand up by himself and walk in the room with a crunch. So this means cranioplasty may be very important for maintaining good brain function. But besides this, clinically we can do, but some patients we need further treatment for consciousness improvements. But clinically we have no special treatment for DOH patients, such as the hyperbaric oxygen, such as the music therapy, stimulation therapy, medicine, amyloiding. Clinically we know no obvious effect for these patients. There are still arguments. How can we help these patients? The key point is the consciousness mechanism. As we know now, the neuromodulation is the most promising technique for these patients. Some non-invasive and invasive DBS, ACNS technique. There are some paper released reported there are different effects for these patients. Now this is the summary by Jacobo. Deep stimulation, vagus nerve stimulation, and RTMS, TDS will have a different target and different parameters. And this paper have the RTMS on the angular gyrus. They have more than 38 cases. They show that in the minimal conscious state, the patients after RTM can improve the consciousness level, but for the unresponsive wakefulness syndrome, no. And in this case, they combine the TDCS and the RTM together simultaneously on the IPL region. The patients showed increased on the CIS scale. But all this case is very lucky. We have they are still arguments not for everyone. How can we help more patients? So the consciousness network, the consciousness mechanism research is the basis for further treatment. As we know, TBI patients or stroke patients, they have variance in consciousness level, such as the coma, UWS, and MCS, and recover consciousness with region. They have a natural model for consciousness research with the states of the sleep and anesthesia. This paper, we have 99 acquired brain injury patients. We make a functional MRI scan with the resting state analysis. We find that the whole brain average functional connectivity strengths correlated with the consciousness level. Yeah, the control is good, but in the UWS and coma is bad. We find that the region in left inferior parietal lobe and posterior cingulate cortex, PCC and PCU, the precuneus region, they have a functional connectivity strengths correlates with the consciousness level, including the GCS and the CIS. The functional connectivity strengths in the in the PCC and the precuneus also related with can predict the patient can recover consciousness or not 3 months later. The predicted accuracy is about 81%. This paper we further research for 59 UWS patients and 26 minimal consciousness patients. We find the salience network correlated with the consciousness level. Default model network, in default model network, the functional connectivity between the left lateral parietal cortex and the posterior cingulate cortex can correlate with the patient's prognosis, can recover consciousness or not, can emergency from UWS or not. From the bifrontal contusion patients, this kind of patients have keep the posterior part of brain well. We find that the functional connectivity across the hemisphere is more correlated with the consciousness level, not the intra-hemisphere. And with the longitudinal function MRI for DOC patients, we find the low frequency amplitude of the PCC and PCO region significantly correlated with degree of the consciousness recovery. In the echo and the no echo auditory task, we find that the midline posterior region correlated with the resonant state and low frequency amplitude. Besides the cerebral cortex network, we also find the neurotransmitter correlated with consciousness. This is our from Maximillian Mehdorn research. We found the GABA receptor, binding the potential value correlated with the consciousness level. The GABA receptor, the binding potential can be a marker of the consciousness recovery after 3 months. From this figure can show that the CIS increased and distinct from the not recovered consciousness group patients. From this research, we find that the PCC region and the IPL region and the TBJ region, all this region can be potential location for neuromodulation. With the acquired brain injury, we combined the sleep and anesthesia patients. We find the function analyzer find a high order the sensory motor circuit, including the supplemental motor area, bilateral supramarginal gyrus, including the inferior palatal lobe and the supragenial anterior cingulate cortex. The circulate color is the main. You can make is the region maintain the consciousness. With this mechanism research, how can select appropriate the patient for neuromodulation? So we must assess the consciousness level. In this research, we adopt a new Chinese language paradigm that elicits the rhythmic brain response, checking the monosyllabic words and two words phrase and the sentence, full words sentence rhythm in speech to examine whether bedside electroencephalography recording can help inform diagnosis and prognosis. We analyze the inter-child phase coherence and the dynamic global brain state. from this figure, we find that this water level tracking measured by the 4 Hertz ITPC was significantly in the healthy group, in the MCS group, in the UWS group, but for the phrase level, we can the phrase level, 2 words is the 2 Hertz ITPC was significantly in the healthy group, and marginal significant in the MCS group, and not in the significant in the UWS. In the sentence, only in the sentence checking measured by the 1 Hertz, the ITPC was significantly only in the healthy control group, not significantly in the MCS and UWS group. This is the temporal dynamic of the global brain state, the micro state analyzed from this is the 4 states, A, B, C, D. A, B means the more closely related to the attention and the salience network. It's a high level cognitive neural network. C, D is related to the auditory and the visual sensory network. Is low level sensory network. In the healthy group, this is the healthy group control the demonstrate a pattern of the high probability of the AB state and the low probability as the CD state. But in minimal conscious state and UWS state have the opposite pattern with low probability of the AB state and high probability of the CD state. But in phrase and the sentence, the UWS and MCS has this thing have obviously difference. And this is the difference of the data CP between the MCS and the UWS was significantly larger in the phrase and the sentence condition than in the resting state and the word condition. The positive and the highest data CP potentially indicates the residue consciousness. So this residue consciousness can be in the minimal state, not in the UWS state. You know that UWS, yeah. We also want to make a prognosis prediction. So we established the prognosis prediction model with the machine learning. Well, we have 4 features of the phase coherence and 4 features of the micro state. And we find 60% of patients with the UWS classified by the clinical diagnosis were classified by EEG, means it's the minimal conscious state. These patients will with the follow up show the good prognosis. We also find that we also predict recovery success rate with the CIS score. It's about 47%, and with the EEG, make a prediction. We can increase the predict recovery success increase to 87%. So we made a bedside EEG assessment and with the Chinese semantic task. This is the ITPC, this is the brain microstate. This is the somatosensory evoke potential and brain connectivity. This is our multimodal neuroimaging in patients with disorder of consciousness. This is our brain spinal cord synchronous MRI scan. This is our quantitative pain stimulation with Trappist pathway system, the functional board MRI. This is our functional analysis. This is our structural analysis. Can show the DTI check. This is our spinal thalamic check. This is cortical spinal check. If this check is keep well, so this patient is suitable for SCS implantation. This is so it's so with these assessments, then we can make a neuromodulation. As we know, we can do the TMS and SCS and the DBS. We can various paradigm for these patients. But what's the best choice for the patient? This is still very difficult to decide. This is our RTMS neuromodulation with neural navigation. This is our DBS neuromodulation. Yeah, this is our DBS implantation. In our group, we put the DBS in the PCC region based on our previous research. Usually, more in other group, we maybe prefer Zelemus region. This is our assessing protocol by the behavior CIS score and the EEG and the functional connectivity analyze. This is one case patients with DBS. This is 5 months after brain injury in the vegetable state. This is 1 year later, the patient can walk. This is one case of TBS, not in the minimal conscious states. Yeah, so 3 months later, after TMS, the patient can move his finger as forward. This is our neuromodulation protocol for disorder consciousness. We analyze the network and the EEG and localize the brain region and have the targets and make DBS implantation. In China, the SCS, this is the trend previous 2 years, about 560 cases SCS for disorder of consciousness totally. And in the 2 years have totally 64 cases of DBS for disorder of consciousness. Now this is TMS, TDCS, and VNS and DBS, SCS the neuromodulation in Beijing group. They have total effective rate about 60 to 70 efficiency. In the future, now we have bedside conscious EEG evaluation system and brain image conscious aid the diagnosis and the cloud platform. And we establish the consciousness disorder sample bank, including the neural imaging and the EEG data and the blood sample and the CSF fluid sample. And we want to, with the help of a tiny platform, multi-dimensional and multimodal research platform, include the monkey research and PET-CT, PET-MRI, and biological research for the neural circuit to know the consciousness mechanism further. For patients, with the development of the consciousness mechanism, we can more precise detect and assess the conscious network of the brain injury and select and try best to select the appropriate modulation method for this patient and achieve personalized neuromodulation and cultivations as soon as possible. Thank you.
Thank you, Professor, for your very interesting and insightful talk. I personally enjoyed very much the first clinical cases in the beginning of the presentation and the last two videos. I have some questions if the audience does not have any questions. Of course, the mechanism of consciousness is the key factor here. If we do not fully understand this mechanism, we cannot treat effectively these patients, but we have many more options nowadays, and there is hope for these patients. So you mentioned some results regarding your patients. We all know that neurosurgery is a teamwork. We all know that treating patients with brain injury is also a teamwork. Could you please tell us something more about the disciplines which were involved in the evaluation of these patients? It was not only about neurosurgery.
You means how to evaluate these patients?
I mean, your collaboration included other medical disciplines. I suppose you worked with neurologists or physiotherapists or even more disciplines. Could you please tell us one or two words about that?
Thank you for the question. Yeah, so this is we have cooperated with the research for other basic research group. Such as the EEG research, we cooperate with the Chinese Academy Institute, the scientists, and the function MRI analyzer. We also cooperate with some functional specialists together. Also, our group can analyze the function MRI EEG data.
Okay. Are there any patient support groups in China that could raise awareness about this condition and maybe speak with the patients and send them to you?
Yeah, such as the DBS implantation. Yeah, we have functional neurosurgery together. Yeah, to this work. Yeah, this research.
Okay. Do you personally have any experience with spinal cord stimulation in treating such patients, or only with deep brain stimulation?
SCS is more easy than DBS, and DBS also is more expensive. And for some patients with cranioplasty, with titanium and revisions, SCS can do, but DBS is not suitable.
Okay. And when somebody would like to try the SCS option, where should one place the leads? At C2, so at the highest possible level?
Sorry, about the pattern?
Where would you place a lead in the spinal cord, in the cervical area, at C2, C3? Do you have any suggestions about that?
What's?
If we are performing a spinal cord stimulation, we have to implant a lead near the spinal cord. Where should we?
Okay. Yeah. So cervical cord, level 2 to 4.
Okay.
Yeah, extradural space.
Okay, and one last question for me, so that the colleagues can also ask if they want something. Do you see that artificial intelligence or this machine learning could help us to use all this data that we collect with EEC or functional MRI to provide a better therapy for the patients, or it is science fiction? What do you think?
Yeah. Clinical is very difficult, and EEG function MRI analyze also is very complicated. This is need a very good group cooperation to design the the EEG protocol and the function MRI protocol and analyze this data and make a very good protocol to design the best choice for these patients and discuss with their relative and the possible results. So this is not easy, not easy. So we try best to help these patients. Yeah,
it's not easy. This is true. Professor has raised his hand. Yes, please, Professor Mehdorn.
Yeah, I enjoyed very much listening to your very, very impressive talk. Thank you very much for giving all the information. I have just a simple question. You have a huge group of people. What's the role of Professor Nordhoff, who is a German, obviously, and working somewhere else? And what's the role in your group? What's his influence? That's one thing. The other thing, what's the influence of the patient? You have a huge group centered around the patient. What's the ethical implication? How do you talk? Because the patient, you cannot talk to the patient, but how can you talk? What do you tell the relatives? You say from your early experience, they have a 30% chance of improving something. And I know the picture, I have seen your videos. I know the videos of Brother Yamamoto and from Japan. And I was not really convinced that we do very much good to these patients. So what do you tell the patients?
About the 30 to 40 efficiency, this is not reported by our group. This is another group. In our group, we select the patients very strictly, so I have no much cases for these patients. I mainly we select patients strictly. We must analyze this data, the function MR and the EEG data. And we first and help the patients with routine clinical techniques such as the hydrocephalus and cranoplasty. And
okay, no problem. But when you go for stimulation,
what?
When do you go? When you suggest the patient to go for stimulation, what do you think? What's the ethical implication of this? Whom do you talk to, or do you talk to the relatives? And I know the Chinese situation when patients very often have to pay themselves, and what's the continuation of care and all these problems? How do you treat this?
Yeah, it's a very, very good question. In our group, from now in our group, for DBS and SCS are all free. Because I have for SCS patient, we have a donation from enterprise, 2 million RMB, for this patient. For DBS, I do 8 patients for DLH patients. This is donated by the DBS enterprises. So this is our research. So I have not open for this patient clinically. So I want to when I finish my this clinical research, if we have find a very good method to assess and select the appropriate patients, maybe I can clinically use the broadly for DLH patients.
Okay, thank you.
But do you have any problems with the relatives of the patients? Are they accepting this as an option to stimulate?
Yes, yeah. Therefore, we must tell their relatives what's the effect will may be. We cannot. I do not convince the absolutely efficiency for the patient. We don't know. We don't know. If he want to try, we will try to help them, but we don't know what's the results will be.
Okay.
And would you select these patients on the basis, or potential patients for deep brain stimulation or spinal cord stimulation? Would you select them on the basis whether they live in Shanghai or whether they live in the rural areas? because that's a huge gap in China, similar in Germany, but maybe it's even more important in China.
Yes, the patients in Shanghai is the medical center in east of China, and many patients come from the other province. Yeah, before they come to the Shanghai, we must tell him the patient condition in detail. We tell them the hope to recover consciousness is very difficult. We cannot sure to improve. Usually the patient relative will want to try every chance to help patients. So, but some patients is obviously no hope patient. I will tell them directly that we cannot help, we will not do anything. But some potential, we can, according to patient's CT scan and the patient's behavior assessments, and such as the visual check. I believe maybe we can analyze their functional connectivity and EEG assessments can try best to help patients.
Impressive. Thank you.
Thank you.
Any other questions from the
Can I
audience?
ask a question, Dr. Matis? Yeah, thanks, Professor Wu. I have two questions for you, Professor. Firstly, regarding the different conscious state. In my country, it's very important, especially in compensation, where patients with persistent vegetative state tend to be compensated lower than those with minimal conscious state, simply because they are shorter life expectancy. As a medical practitioner, how sure are we that when one person been diagnosed as persistent vegetative state, that would not reverse and become better to a minimal conscious state? How long do we wait to be ascertained in court? My second question, Professor, regarding the physical therapy. And there's many papers have proven that in patients in stroke who have extensive physical therapy, we have better improvement in motor system. Do you think that physical therapy also can be used in terms of improvement conscious level or consciousness as part of the neuromodulation? Thank you, Professor.
I interrupt before you go on with your second question. I think it is not a question of choosing between physiotherapy or neuromodulation. It is the combination of both options that could offer an advantage to the patients. Neuromodulation cannot be the only therapeutic option. It's only a part of the treatment, and physiotherapy is an integral part of the treatment. And it doesn't matter if it is diseases, disorders of consciousness, or chronic pain, or something else. Physiotherapy is always a must. Sorry for the interruption.
Yeah, thank you, Dr. Martin. And the second question, Professor, how sure that when we diagnose a person with a persistent vegetative state, that the person will not recover to a better state?
How to recover? What?
Yeah, I mean, when we put a diagnosis of person with a persistent vegetative state, how sure are we that the person will not recover to minimal conscious state? Is there any time limit for them to improve?
How to improve the minimal conscious state patient's consciousness?
Yes. Do you have patient that with diagnosed with persistent vegetative state that improve to minimum? What's the criteria?
Just the case.
Yeah. Do you have any case that already diagnosed as persistent vegetative state but later improve to minimal conscious state?
Yeah. Clinically, you will have many cases. The patient from the persistent vegetative state to minimal conscious state, such as the cases I presented, the female in the persistent vegetative states with the high surveillance. Yes, some patients, this kind of patients, the hydrocephalus affects the consciousness level distinctly. If we management the hydrocephalus precisely and let the ventricle recover to the normal size, the patient, the consciousness can recover obviously. In some patients, clinically, I have so many cases. Maybe the patients in persistent vegetable stage for more than 1 year, 4 years. The second elderly patients just in 4 years, the patient consciousness improved. Distinctly. Yeah. So maybe long time, but we cannot treat the patients not precisely. So we maybe the patient also have a chance. Yeah, beside the clinical routine measurements, neuromodulation just a promising technique. We can try. We can do more research to help patients.
Thank you very much, Professor Wu. Probably we can call upon Dr. Mattis to do a concluding remark. Dr. Mattis.
I just want to make a comment. We urgently need research in this topic, but we should not forget that it's a very expensive therapy. Spinal cord stimulation, or even worse, deep brain stimulation, is unfortunately a very expensive therapy. On the other hand, we must operate more patients with disorders of conscience in order to get some data and to understand if this therapy can really help these patients or not, or which type of stimulation, for example, would be the most appropriate to treat such patients. Today, we have many new things that one can try, but in order to try them, we have to implant a lead. In order to implant the lead, we have to have the money to do it. So I think the most realistic approach is a cooperation with the big companies which are selling these products in order to have the possibility to do that. This is an exciting topic. I'm sure we can help these patients, but we must do it in the correct way. And to do so, we need more data. Thank you.
Thank you.
Thank you, Dr. Mattis, and thank you, Professor Wu. Also, thank you to Professor Maruyama and Professor Mehdorn for participating in our webinar today. So on behalf of the Education Committee of the ACNS and the Professor Yoko Kato, I would like to thank both speakers of today, Professor Maximillian Mehdorn and Professor Wu Xuehai, and as well as our chairs, Professor Takashi Maruyama and Professor Georgios Mattis for the time and support for the. So until we meet again tomorrow, is bye-bye from all of us. Thank you, Professor, for joining.